Welcome back to the deep dive. Today we're plunging into a topic that, well, it affects millions worldwide, yet often remains a silent threat, hiding in plain sight right there in the legs. It's a condition that serves as a really critical warning signal for the entire cardiovascular system.
That's right. We're taking a deep dive into lower limb peripheral arterial disease, or PAD as it's often called. And we're specifically focusing today on those patients who haven't yet developed the really severe symptoms, so the asymptomatic stage and the classic presentation of intermittent claudication.
And our guide for this, our source material, it's pretty substantial. We're working from a really comprehensive set of guidelines published by the European Society for Vascular Surgery, the ESVS. So this isn't just one study, it's a consensus document built on extensive research and expert opinion designed to help you, our listeners, understand the latest evidence-based approaches.
Exactly. Our mission here is really to unpack the most important insights from this guideline. We'll help you understand the disease process itself, identify who is most at risk, review the latest diagnostic approaches, and really delve into the nuances of both medical and interventional management. Think of it as a shortcut to being really well informed on the cutting edge of PA care.
Okay, let's get into it then. First off, what exactly are we talking about when we say peripheral arterial disease, specifically in this context?
Right. So at its core, lower limb peripheral arterial disease is predominantly caused by atherosclerosis. That counts for approximately 95% of cases.
Okay, atherosclerosis, that's the plaque buildup, right?
Exactly that. It's that process where plaque, fatty deposits, and other substances builds up within the arterial walls. This leads to narrowing or stenosis or even complete blockage, occlusion of the arteries.
So it's like pipes getting clogged up.
Precisely. But these are the body's vital arterial pipes. Typically, we're talking from the infrarenal aorta, that's the section of the main artery below, where the kidney arteries branch off all the way down through the legs to the smallest vessels in the toes. And this narrowing or blockage, well, it reduces blood flow to the muscles and tissues in the lower limbs.
And these specific ESVS guidelines are zeroing in on particular patient groups.
Yes, that's important. This guideline focuses specifically on two main categories of lower limb PAD patients. Those who are asymptomatic, meaning they have objective evidence of the disease, like a low ankle brachial index, but no classic leg symptoms during exertion. And those with intermittent claudication, which is that characteristic exercise-induced pain, usually in the calf, thigh, or buttock.
It seems really important then to note what this guideline doesn't cover as well.
Absolutely. Crucial distinction. This document deliberately excludes the management of chronic limb-threatening ischemia, or CLTI.
That's the really severe end of the spectrum.
Exactly. That's the most severe form, often presenting with pain even at rest, non-healing ulcers, or gangrene. That complex area is covered by other recent guidelines from the ESVS. It also doesn't address acute limb ischemia, that's a sudden severe blockage, often caused by a clot, an embolism, or thrombosis, which is a vascular emergency.
Okay.
And it also doesn't cover the less common causes of PAD, things like vasculitis, which is inflammation of the blood vessels, or hereditary conditions, trauma, popliteal artery entrapment syndrome, or cystic adventitial disease. This guideline is strictly focused on the atherosclerotic, non-critically ischemic presentations.
Got it. So atherosclerotic disease, infrarenal aorta, down to the toes, specifically in patients who are asymptomatic or just have intermittent claudication. Okay, so how common is this condition, especially the silent or mildly symptomatic forms?
It's remarkably prevalent and, often really underestimated. Global estimates back from 2015 suggested around 237 million people aged 25 and older were affected by peripheral arterial disease worldwide.
Wow, 237 million.
And that was an increase from about 202 million just 5 years earlier, in 2010. But here's where it gets, well, particularly clinically relevant. Numerous studies consistently show that asymptomatic PAD is actually more prevalent than the symptomatic form, the intermittent claudication.
Right, that's the silent aspect you mentioned earlier. Do we have some specific numbers on that?
We certainly do. The Partners study, for instance, which actively screened patients in primary care settings, found that nearly half, 48%, of newly diagnosed PA cases were actually asymptomatic. They had a low ABI but no claudication symptoms.
Almost half.
And then there's the Edinburgh Artery Study. This looked at community-dwelling individuals who had a low ankle brachial index consistent with PA. It found that a staggering 84% of them reported no exertional leg symptoms whatsoever.
84%. So the vast majority of people with objective evidence of reduced blood flow in their legs don't actually have that classic walking pain. That's really significant, isn't it?
It's huge. It tells us we can't just wait for patients to complain of claudication.
So who typically is at risk for developing this? Who should we be thinking about?
Well, incidence increases quite significantly with age. It's relatively rare before the age of 50, but rises steeply after that. But the key risk factors are those major modifiable ones we see across cardiovascular disease generally: smoking, diabetes mellitus, high blood pressure or hypertension, and elevated cholesterol levels or hyperlipidemia.
Okay, the usual suspects.
Pretty much.
Yeah.
But the guidelines specifically emphasize smoking and diabetes as the two strongest associated risk factors for developing PAD. They're really powerfully linked, both to having asymptomatic PA and also to the progression of blockages if you already have symptomatic PAD. Remember those two. Smoking and diabetes are paramount.
So a quick board-style question for you listening.
Yeah.
What are the two strongest modifiable risk factors mentioned here?
Right, that would be smoking and diabetes.
Yeah.
If you see an older patient, especially one with a history of smoking or diagnosed diabetes, PAD should definitely be on your radar, even if they aren't complaining of leg pain when they walk.
Absolutely. And that leads us directly to a really crucial point. PAD isn't just a problem isolated to the legs, is it?
No, absolutely not. It's a manifestation of a systemic disease process.
Right, systemic atherosclerosis.
Exactly. Because atherosclerosis affects arteries throughout the body: coronary arteries, carotid arteries, renal arteries, you name it. Having PAD is a powerful warning signal. It tells you that that individual is at a significantly increased risk for other serious cardiovascular events. We're talking about heart attack, myocardial infarction or MI, and stroke.
Can you give us a sense of the magnitude of that increased risk? How much higher is it?
Yeah, there's some striking data. One key finding comes from the Ankle Brachial Index Collaboration Study. This was a large meta-analysis of population-based data. It showed that the 10-year risk of dying from a cardiovascular cause in men who had a low ankle brachial index, defined as less than or equal to 0.90, was 18.7%.
Wow, almost 1 in 5 over 10 years.
Compare that to men with a normal ankle brachial index, say between 1.11 and 1.40. Their 10-year cardiovascular mortality was only 4.4%.
That's a dramatic difference, more than 4 times higher.
It really is. And for women, the numbers showed a similar pattern: 12.6% 10-year cardiovascular mortality with a low ABI versus 4.1% with a normal one. So the takeaway is stark. A low ABI, even in someone completely asymptomatic, flags a significantly higher risk of dying from a heart attack or stroke down the line. That low ABI is a major prognostic marker.
That's a really stark difference. It absolutely underscores why detecting this, even in that silent phase, is so critical for overall cardiovascular risk management, not just limb health.
It truly does. And this condition, PA, it frequently overlaps with other cardiovascular conditions, particularly coronary artery disease, CAD. The source guideline notes that PA is present in a significant proportion of patients who have evidence of CAD on angiography.
And having both is worse.
Much worse. Having PAD in addition to CAD is consistently associated with poorer outcomes across various endpoints. We see higher rates of in-hospital death, acute heart failure, recurrent ischemia after coronary events, and worse outcomes even after procedures like percutaneous coronary intervention, PCI, to open up coronary arteries. PAD acts as an independent predictor of mortality in these patients.
So thinking practically, if you're managing a patient with known CAD, maybe actively screening them for PAD with something relatively simple, like an ankle brachial index, could potentially add really valuable prognostic information about their overall risk profile.
That's certainly the argument, yes. Although it's fair to note the source mentions a small trial, the America trial, which looks specifically at proactive screening in patients with known polyvascular disease, meaning disease in multiple arterial beds. That trial didn't demonstrate a clear benefit in terms of outcomes from that proactive screening approach.
Okay.
However, the guideline authors point out that the trial had limitations, and it doesn't definitively rule out a role for screening, particularly in this very high-risk population, maybe more for understanding their future risk, rather than directly changing immediate management in all cases.
Interesting nuance there.
And another connection the guideline highlights: in patients who have severe CAD, the presence of either symptomatic or even asymptomatic PAD is associated with a surprisingly high probability, almost 20%, of also having significant carotid artery stenosis. It really underscores how interconnected this disease process is.
It's all linked. We should probably also touch on the connection with chronic kidney disease, CKD.
Yes, absolutely. Mild to moderate CKD significantly increases the risk of developing PAD. A large meta-analysis found that both a lower estimated glomerular filtration rate, or EGFR, which measures kidney function, and a higher urine albumin to creatinine ratio, UACR, which indicates kidney damage, were independently associated with the incidence of PAD. So in patients with any stage of CKD, it's really important to be vigilant for signs and symptoms of PAD. Making that diagnosis can lead to optimizing their medical management and potentially improving their long-term prognosis.
Okay, so we've established what PAD is, who's at risk, and crucially, why it matters systemically beyond just leg symptoms. Now, let's get into the practicalities. How do we actually diagnose it? It's clearly more than just waiting for someone to complain of pain when they walk.
Exactly right. While intermittent claudication is the classic symptom we learn about, as we've just discussed, many, perhaps even most, patients are asymptomatic or present with rather atypical symptoms. Let's start with intermittent claudication, though, as it's the most recognizable pattern.
Okay, describe that classic pattern for us again. What are the key features?
The guideline references criteria, often used in epidemiological studies and clinical trials. So, classical intermittent claudication is defined as exercise-induced discomfort or pain in the lower limb that meets these criteria. 1. It doesn't begin when the patient is at rest. 2. It involves the muscles of the calf, thigh, and or buttock. 3. It forces the patient to slow down their walking pace or stop walking altogether. And 4. Critically, it resolves relatively quickly, usually within 10 minutes, once they rest.
And the location of the pain can give clues.
Yes, it often can. For example, pain isolated to the calf muscles frequently points towards blockages in the femoral-popliteal arteries, the arteries in the thigh and behind the knee, whereas pain extending into the thigh or buttock suggests more proximal disease, perhaps in the aortoiliac arteries, higher up near the pelvis. This pain occurs because the metabolic demands of the exercising muscles outstrip the reduced oxygen supply available due to those narrowed or blocked arteries. It's an oxygen supply-demand mismatch.
Makes sense. Now, what about those atypical symptoms you mentioned, particularly in patients who might otherwise be classified as asymptomatic?
Right. Even without that classic claudication pattern, patients who have objective evidence of PAD, like a low ABI, might experience other things. This could include altered sensation in their feet or legs, perhaps a feeling of numbness, tingling, weakness, or even just calf muscle cramps that aren't necessarily related to exertion in the classic way. The guideline really stresses the importance of considering PAD in patients who have risk factors and report any of these sorts of lower limb symptoms, even if atypical. It warrants a proper medical evaluation.
So the history taking is absolutely key, digging into even those subtle or unusual symptoms. What about the physical examination? What should we be looking for?
A thorough vascular examination is essential. You should assess the pulses bilaterally, comparing side to side. This means palpating for the femoral pulse in the groin, the popliteal pulse behind the knee, and then the posterior tibial pulse behind the medial malleolus at the ankle, and the dorsalis pedis pulse on the top of the foot. It's also good practice to palpate the brachial pulses in both arms, partly for comparison when doing the ABI, but also as a general vascular assessment.
Okay, checking those pulses gives a qualitative sense of flow. But what's the cornerstone of the objective diagnosis?
That would undoubtedly be the ankle brachial index measurement, the ABI. The guideline strongly recommends the resting ABI as the appropriate first-line test to establish the diagnosis of lower limb PAD. This is a Class I, Level B recommendation, so strong recommendation based on good evidence.
Okay, tell us how that's done and interpreted, maybe not every single step like a lab protocol, but the core concept.
Understood. Conceptually, the ABI involves using a standard blood pressure cuff and a handheld Doppler ultrasound probe. You measure the systolic blood pressure in the brachial artery of both arms, and then you measure the systolic pressure in both the dorsalis pedis and posterior tibial arteries at each ankle.
Oh.
To calculate the ABI for each leg, you take the highest of the two ankle pressures, either posterior tibial or dorsalis pedis, on that side, and you divide it by the highest of the two brachial pressures measured in the arms.
Highest ankle pressure divided by highest arm pressure.
Exactly. Normally, the pressure at the ankle should be the same or even slightly higher than in the arm, so a normal ABI is typically 1.00 or slightly above, up to 1.40. A value below 1.0 indicates some reduction in blood flow reaching the ankle.
And what's the specific diagnostic cutoff value recommended in these guidelines?
The guideline recommends using an ankle brachial index value of less than or equal to 0.90 for the diagnosis of lower limb PAD. This is a Class I, Level C recommendation, strong recommendation based on consensus or less robust studies, but widely accepted. So, 0.90 or below confirms PAD. Remember that cutoff, ABI 0.90.
Okay, ABI 8.90. What if the ABI comes back high, say 1.4 or greater? What does that signify?
Right, an ABI value of 1.40 or greater is often considered inconclusive or indicates poorly compressible arteries. This happens frequently in patients with longstanding diabetes or significant chronic kidney disease because their arteries become stiff and calcified.
The cuff can't squeeze them properly.
Exactly. The cuff pressure required to stop the blood flow becomes artificially high, leading to a falsely elevated or non-recordable ABI reading. It doesn't rule out PAD, it just means the ABI test itself isn't reliable in that situation.
So if the ABI is inconclusive like that, or perhaps if it's normal between 0.91 and 1.39, but you still have a high clinical suspicion of PAD based on symptoms or risk factors, what next?
In those specific situations, the guideline recommends that the use of the toe brachial index, or TBI, or alternatively measuring absolute co-pressures, should be considered. This is a Class 3, Level B recommendation, meaning it's reasonable to do this based on good evidence.
Why toe pressures?
Because the very small arteries in the toes are much less likely to be affected by that medial calcification that makes the ankle arteries incompressible. So measuring pressure at the toe level can often reveal underlying PAD even when the ABI is normal or falsely elevated.
That makes sense. Beyond the ABI and toe pressures for diagnosis, how do we assess the functional impact, especially in patients with intermittent claudication? How limited are they?
Walking tests are the standard approach here. Treadmill tests are commonly used to objectively measure how the disease affects a patient's walking ability. You can measure things like the distance at which pain starts, the pain-free walking distance, and the maximum distance the patient can walk before needing to stop, the maximum walking distance. The maximum walking distance is noted as being reliable. That's a Class IAB Level C recommendation.
Are there alternatives if a treadmill isn't available or suitable?
Yes, corridor walk tests, where the patient simply walks back and forth along a measured course in a hallway, often for a set time like 6 minutes, the 6-minute walk test, are also used. The guideline mentions these might potentially better reflect a patient's typical daily walking situation compared to the somewhat artificial setting of a treadmill. They also avoid the potential learning effect, sometimes seen with repeated treadmill tests.
Okay, so ABI is the primary diagnostic tool, potentially supplemented by toe pressures, and then walking tests help quantify the functional limitation caused by the disease.
Exactly. That gives you the diagnosis and a measure of severity.
Right. Now let's transition to actually seeing the arteries themselves. Imaging. When do we need to visualize the blockages, and what are the main options available?
Imaging becomes necessary, primarily when you are seriously considering performing a procedure to open up blockages, what we collectively call revascularization for a patient with PAD, typically one with disabling claudication who hasn't responded adequately to conservative therapy. You need a roadmap to see the location, length, and severity of the arterial lesions before planning any kind of intervention, whether it's endovascular or open surgery.
Okay, so it's mainly for pre-procedural planning. What are the recommended primary imaging modalities according to these guidelines?
The guidelines recommend duplex ultrasound, computed tomography angiography, CTA, or magnetic resonance angiography, MRA, as the primary imaging modalities. This is a Class I, Level C recommendation. The choice among these three is generally left to the discretion of the treating physician and depends on local expertise, availability, and specific patient factors.
Can we briefly touch on the pros and cons of each as mentioned in the source?
Sure. Duplex ultrasound is non-invasive, uses no radiation or contrast dye, and can provide information about blood flow dynamics, like the speed of flow through a narrowing. However, its quality is highly dependent on the skill of the operator and can be limited by factors like patient body habitus or bowel gas.
Okay, TTA.
Computed tomography angiography provides excellent, detailed anatomical images of the arteries and is particularly good at showing calcification within the vessel walls. But it involves significant ionizing radiation exposure and requires intravenous iodinated contrast dye, which carries a risk of contrast-induced nephropathy, especially in patients with pre-existing kidney dysfunction.
Right, the kidney issue.
And MRA. Magnetic resonance angiography, particularly when performed with gadolinium-based contrast agents, is very sensitive for detecting stenosis and occlusions and avoids ionizing radiation. However, it can be problematic for patients with certain metal implants or pacemakers. There are also concerns about gadolinium deposition in patients with severe kidney disease, though newer contrast agents are safer. Claustrophobia can also be an issue, and MRA isn't as good as CTA at visualizing calcium.
Got it. What about the tests that, used to be considered the gold standard for looking at arteries?
You're probably thinking of digital subtraction angiography or DSA. Historically, yes, it was considered the gold standard, but it's largely been replaced by these non-invasive or less invasive methods, duplex CTA, MRA for the initial diagnostic workup and planning.
So where does DSA fit in now?
Now, DSA is more considered an adjunct tool. It's typically used if the non-invasive imaging results are inconclusive or don't provide enough detail for planning. And most often, it's performed immediately before or actually during an endovascular intervention because it is itself an invasive procedure. It allows real-time imaging as catheters and wires are navigated and treatments like angioplasty or stenting are performed.
And you mentioned it's invasive. What are the main drawbacks of DSA?
Yes, it's invasive, involving puncturing an artery, usually the femoral artery, and advancing catheters. It involves radiation exposure, often more than CTA depending on the complexity, and it requires contrast agents, typically iodinated contrast, with the associated risks of allergic reaction and kidney injury. For patients with severe CKD where iodinated contrast is contraindicated, sometimes carbon dioxide CO2 can be used as an alternative contrast agent during DSA, though CO2 angiography has its own potential side effects and limitations in image quality, especially below the knee.
Okay, that clarifies the imaging options. Now, before we jump into the specifics of interventions like angioplasty or surgery, the guidelines strongly emphasize that revascularization is often not the first step, particularly for intermittent claudication. What are the foundational pillars of managing PE, especially in these asymptomatic and intermittent claudication stages?
That's a critical point. The overall goals of treatment in this patient population are twofold. First, we want to decelerate, or ideally stop, the progression of the underlying systemic atherosclerosis. Second, we want to reduce the patient's risk of both major cardiovascular events, heart attack, stroke, cardiovascular death, collectively known as AME, and major adverse limb events like progression to critical limb ischemia or needing an amputation known as MALE.
And achieving those goals starts with lifestyle modifications, right?
Absolutely. Lifestyle changes are foundational, non-negotiable, and arguably the most impactful interventions we have. And number one on that list, without a doubt, is smoking cessation.
You mentioned it as a top risk factor earlier.
And it's the top target for intervention. This is arguably the single most important factor in managing PAD. The guidelines strongly state Class 1, Level AB evidence that counseling combined with pharmacotherapy, like nicotine replacement therapy, NRT, bupropion or varenicline, are effective for achieving smoking cessation. And crucially, quitting smoking is associated with decreased all-cause mortality and improved amputation-free survival in PA patients. It's hard to overstate its importance.
So every effort must be made to help patients quit. What else on the lifestyle front?
A healthy diet and weight reduction, if applicable, are considered integral parts of the best medical treatment strategy. And then there's physical activity.
Now, exercise is often talked about specifically as a treatment for claudication symptoms to improve walking distance, but the guidelines seem to position it more broadly than that.
They absolutely do. For all patients with lower limb PAD, and this explicitly includes those who are asymptomatic, it is strongly recommended Class 1 Level A evidence that they should strive for at least 150 to 300 minutes per week of moderate intensity aerobic physical activity. Or, alternatively, 75 to 150 minutes per week of vigorous intensity aerobic physical activity. This recommendation isn't just about making legs feel better. It's aimed squarely at reducing overall mortality, cardiovascular mortality, and cardiovascular morbidity in this high-risk population.
Oh.
Exercise is a systemic treatment for these patients.
So to be clear, even if a patient has a low ABI but no walking symptoms, they should still be strongly encouraged to engage in regular aerobic exercise for its overall cardiovascular benefits.
Precisely. It's a core component of risk reduction for everyone with PAD. Okay, moving on from lifestyle to medical management, optimizing control of associated conditions is vital.
Let's start with high blood pressure, hypertension.
Optimal management of hypertension is recommended. That's a Class I, Level C recommendation. An important practical point the guideline makes is regarding beta blockers. Historically, there was some concern they might worsen claudication symptoms.
Right, I remember that being taught.
But the evidence doesn't really support that fear. The guideline explicitly states that beta blockers are not contraindicated in patients with intermittent claudication and, in fact, may be considered Class IB, Level B. So if a patient has another compelling indication for a beta blocker, like heart failure or post-MI, you shouldn't withhold it because they also have PA.
Good clarification. What about lipid management? Cholesterol?
Again, optimal lipid-lowering therapy is strongly recommended, Class Y and Level C. And the cornerstone here is statin therapy. Statins are recommended for patients with lower limb PAD. That's a very strong class I, level A recommendation.
Does that apply across the board, even in older patients?
Yes, the recommendation explicitly includes older patients, even those over 80, although the guideline advises exercising caution if they are frail on many other medications, polypharmacy, or have severely impaired liver or kidney function. Monitoring long-term prescription rates and, importantly, patient adherence to statin therapy is also recommended as part of quality care, class I, level C.
Okay, statins are key. What are the specific lipid targets the guidelines recommend aiming for in PAD patients? This seems like a really important detail.
It is, and it's quite aggressive. Here's a crucial takeaway from the 2023 ESC guidelines that these PAD guidelines align with. For patients with lower limb peripheral arterial disease who are automatically classified as very high cardiovascular risk, it is strongly recommended, class I, level B, to reduce the low-density lipoprotein cholesterol, the LDLC, concentration to less than 1.4 millimoles per liter. Now, that's equivalent to less than 55 milligrams per deciliter.
Less than 1.4 millimole or 55 milli-GDL.
And there's a second part to that target. You should also aim for a decrease in LDLC of 50% or more from the baseline level if their starting LDLC was between 1.4 and 2.8 millimole, or 55 and 110 milli-GDL. So it's both an absolute target and a relative reduction goal. Remember that dual LDL target, 1.4 millimole, 55 milli-GDL, and EOHM 50% reduction.
That is a pretty aggressive target for LDL cholesterol. What if that target isn't met with a high-intensity statin alone, along with lifestyle advice?
Good question. For patients who are unable to achieve these LDL targets despite adhering to lifestyle advice and taking the maximally tolerated dose of a high-intensity statin, the addition of ezetimibe is recommended, class I, level C. Ezetimibe works differently by inhibiting cholesterol absorption in the gut and can provide significant additional LDL lowering when combined with a statin. This is supported by major trials like IMPROVE-IT.
Okay, add ezetimibe if needed. Where do the newer injectable lipid-lowering agents like the PCSK9 inhibitors fit into this picture for PA patients?
The guidelines position PCSK9 inhibitors as more of a second or third line option in this context. They state that for patients who could potentially reach their lipid targets using statin therapy, with or without ezetimibe, PCSK9 inhibitors are not recommended as first-line therapy.
So not for everyone up front.
Right. They are generally considered as alternatives or add-ons for patients who are genuinely intolerant to recommended statin doses or who fail to reach those stringent LDL target levels, even despite combination therapy with a statin and ezetimibe.
Let's touch briefly on statin side effects, particularly the muscle symptoms, statin-associated muscle symptoms, or SAMs, as this is a common reason patients stop taking them, which could be detrimental given the benefits.
Yes, this is a very common and important clinical issue. The guideline acknowledges that while large randomized controlled trials haven't consistently shown a significant increase in muscle symptoms like myalgia with statins compared to placebo, real-world observational studies and patient reports often suggest a higher frequency. It's a bit of a paradox.
Why might that discrepancy exist?
Well, several factors might be at play. Randomized trials often enroll healthier, perhaps more motivated patients, and exclude those with prior intolerance. But the guideline also highlights the potential role of the nocebo effect in non-blinded settings, where patients expect side effects based on reputation or warnings, and thus are more likely to attribute any ache or pain to the drug. Observational studies can also suffer from various biases.
The nocebo effect, the power of negative expectation.
It's exactly. The Samson trial, which was mentioned in the lipid guidelines context, provided some interesting insights here. It was a cleverly designed N-of-1 trial in patients who had previously stopped statins due to side effects. It found that a large proportion of the muscle symptoms patients reported while taking statin tablets were also reported when they were unknowingly taking identical placebo tablets.
Interesting.
It strongly suggests that the expectation or awareness of taking the drug contributes significantly to the symptom burden for many patients. However, despite this, the guideline emphasizes it's crucial to manage reported muscle symptoms effectively, often through strategies like temporary cessation, dose reduction, trying a different statin, or less frequent dosing rather than simply stopping this life-saving therapy altogether. Especially considering other studies showing increased cardiovascular event risk when patients, particularly elderly primary prevention patients, discontinue statins.
Okay, important points on managing statin intolerance. Let's move on to diabetes management. We've established it's a huge risk factor.
Absolutely. Diabetes is a major risk factor for PAD, increasing the risk perhaps 2- to 4-fold compared to those without diabetes. It often leads to an earlier onset of PAD, sometimes presenting at a younger age, and maybe even with fewer other traditional cardiovascular risk factors present.
And does it affect function and outcomes?
Profoundly. Patients with diabetes tend to experience poorer lower extremity function, more walking impairment, slower walking speed, and critically, diabetes significantly increases both mortality and the risk of amputation in patients who also have PAD. Studies consistently show that concomitant diabetes roughly doubles the long-term mortality rate and also doubles amputation rates in PD populations. Even after successful endovascular treatment for claudication, patients with diabetes have higher rates of NVE and major amputation down the line.
So managing the diabetes is paramount.
Absolutely critical. The guidelines emphasize that achieving tight blood sugar control in patients with PAD and established type 2 diabetes is clearly important to improve their long-term prognosis. This is a strong recommendation, Class 1, Level A.
Is there a specific target for blood glucose control mentioned?
Yes. For patients with lower limb PAD and diabetes, it is recommended to reduce blood glucose towards near normal values, specifically aiming for a hemoglobin A1C, HbA1c, level of less than or equal to 7%. That's 53 millimoles per mole in SI units. This target is also a strong recommendation, Class I, Level A, supported by landmark diabetes trials showing microvascular benefits and potentially macrovascular benefits over the long term with good glycemic control.
Okay, target HbA1c A7%. Now, in terms of which anti-diabetic agents to use in PA patients with type 2 diabetes, are there preferred classes based on recent evidence?
Yes, this is a really important update reflecting major trial data from recent years.
Hmm.
For patients with lower limb PAD and type 2 diabetes who require glucose-lowering medication, both sodium glucose cotransporter 2 inhibitors, the SGLT2 inhibitors.
Like empagliflozin, dapagliflozin.
Exactly. And glucagon-like peptide-1 receptor agonist, the GLP-1 receptor agonist.
Like liraglutide, semaglutide.
Precisely. Both of these classes are recommended as first-line hypoglycemic agents. This is a Class I, Level B recommendation. The primary rationale here is their proven ability to reduce the risk of major cardiovascular events, MACE, and also renal events in large outcome trials involving patients with type 2 diabetes and established cardiovascular disease or high risk, which includes PAD patients.
Now, there was some controversy or concern a few years ago regarding a potential increased risk of lower limb amputation with certain SGLT2 inhibitors, wasn't there?
Yes, that's correct. The initial Canvas program trials involving canagliflozin did report approximately a doubling in the risk of major and minor lower limb amputations compared to placebo. This finding led to regulatory warnings at the time.
So has that been resolved?
While subsequent large cardiovascular outcome trials focusing on other SGLT2 inhibitors, specifically empagliflozin in Empiric Outcome and dapagliflozin in Declared Time E58, did not confirm this higher amputation risk. While careful foot monitoring is always crucial in patients with diabetes and PAD, the totality of evidence now, as reflected in this guideline, strongly supports the use of both SGLT2 inhibitors and GLP-1 receptor agonists in appropriate patients due to their substantial proven cardiovascular and renal benefits, which are thought to outweigh that potential risk signal seen with one specific agent in earlier trials.
Okay, that's a very helpful clarification on the current stance. Finally, under medical management, let's not forget about vaccinations.
Right, an often overlooked but important aspect. Patients with PAD are generally older and have multiple comorbidities, putting them at increased risk from infections like influenza and COVID-19. The guideline therefore recommends annual influenza vaccination for patients with lower limb PAD, Class 1 Level C. This is based on studies showing higher risk of severe influenza infection in patients with cardiovascular disease and some observational data suggesting potential cardiovascular benefits from flu vaccination in these populations.
Makes sense. And what about COVID-19 vaccination?
Similarly, full vaccination against COVID-19 disease, according to national recommendations, is also recommended for patients with lower limb PAD, Class Y Level C. This is driven by registry studies, clearly demonstrating that PAD patients were at increased risk of hospitalization with severe COVID-19 illness during the pandemic.
Okay, so that covers the crucial pillars of lifestyle modification and comprehensive medical management: smoking cessation, diet, exercise, blood pressure, lipids with aggressive LDL targets, diabetes with specific agent recommendations, and vaccinations. Now, let's circle back and focus specifically on exercise therapy again, because it's highlighted as such a cornerstone treatment, especially for intermittent claudication itself.
Indeed, for patients suffering from intermittent claudication, the evidence supporting exercise therapy is really robust. Multiple systematic reviews and meta-analyses consistently show that physical exercise programs, particularly those involving walking, significantly increase walking distance, both pain-free and maximum walking distance. They also improve health-related quality of life and enhance overall physical function.
So, what specific types or approaches to exercise are recommended for claudication?
The guideline gives the strongest recommendation, Class 1, Level A to Supervised Exercise Therapy, or SET, for patients with intermittent claudication. SET typically involves sessions conducted in a hospital or clinic setting, supervised by trained personnel like physiotherapists or clinical exercise physiologists, usually 2-3 times per week for at least 3 months. The supervision allows for proper technique, progression, and motivation.
And why is supervised therapy preferred?
Because head-to-head comparisons have generally shown that SET is more effective at improving walking distance than simply advising patients to walk on their own, unsupervised exercise. However, recognizing that SET isn't always accessible or feasible for all patients.
Right, there could be barriers.
Exactly. So the guideline also strongly recommends, again, Class 1, Level A structured home-based exercise programs, or HBET, provided they include some form of behavioral change intervention or support structure. This could involve things like health coaching, activity monitors, regular contact, or structured diaries to promote adherence and progression, trying to mimic some benefits of supervision, but delivered remotely or at home.
So, ideally supervised, but a well-structured, supported home-based program is also a top-tier recommendation. What about using exercise specifically for those asymptomatic PAD patients we talked about earlier?
That's a slightly different scenario. For individuals who have asymptomatic lower limb PAD, example, low ABI but no claudication, the guidelines suggest that supervised exercise programs or structured home-based exercise programs may be considered. This is a Class 2 Level A recommendation. The potential goals here would be to improve overall walking capacity, potentially prevent or delay the onset of claudication symptoms, improve health-related quality of life, and increase general physical activity levels.
But the evidence is maybe less definitive than for claudication.
Exactly. The guideline notes the need for larger, well-designed, randomized controlled trials, specifically in this asymptomatic population, to really confirm the benefits and optimal program structures. However, a small trial mentioned in the guideline, which included mostly asymptomatic patients, did show functional benefits from supervised treadmill exercise compared to a control group. And remember that overarching recommendation.
The general physical activity goal for everyone with PAD.
Yes. Just to reiterate that foundational Class 1 Level A recommendation. For all patients with lower limb PAD, including those in asymptomatic stages, striving for that 150-300 minutes per week of moderate intensity or 75-150 minutes per week of vigorous intensity aerobic activity is crucial for reducing overall and cardiovascular mortality and morbidity. That applies universally.
Got it. Now, despite the strong evidence, particularly for supervised exercise and claudication, you mentioned barriers, what are the common challenges in actually getting patients into and completing these programs in the real world?
Yeah, this is a significant practical hurdle. The guidelines discuss several barriers. From the healthcare system side, there can be limited availability of dedicated SET programs, lack of adequate reimbursement or funding structures, and sometimes insufficient physician awareness or referral rates.
And from the patient side?
Patient barriers are also numerous. They can include things like poor health literacy or understanding of the benefits, having other medical conditions, comorbidities that limit their ability to exercise, lack of motivation or self-efficacy, the claudication pain itself acting as a deterrent, and practical issues like difficulty traveling to sessions, time constraints, or associated costs like transport or copays. Adherence, even once enrolled, can also be low, often dropping off over time.
So it's a complex problem. Are there potential solutions or strategies mentioned to overcome these barriers?
The guideline gives examples. Establishing community-based networks involving physical therapists has been shown in some regions to improve access and referral rates, sometimes linked to better reimbursement models. Helping patients successfully transition from a structured supervised program to a sustainable, long-term, unsupervised exercise habit is also crucial for maintaining the benefits achieved during the initial program.
What about using existing cardiac rehabilitation programs? Could they play a role?
That's an interesting point. A position paper from the European Society of Cardiology, ESC, actually suggests that PAD should be considered a qualifying diagnosis to enter cardiac rehabilitation programs in many countries, as these often have established infrastructure for supervised exercise. The ESVS guideline echoes this, suggesting that participation in an exercise-based cardiac rehab program may be considered. Class I, level C, for patients with intermittent claudication, specifically to improve walking distance and function, particularly when dedicated set programs designed for PIAD are not available or accessible.
So leveraging existing resources where possible, and exercise isn't just an alternative to procedures, it's also recommended alongside them.
Yes, absolutely. Exercise therapy is strongly recommended, Class I, level B, as an adjunct to lower limb revascularization procedures for patients with intermittent claudication. The benefits are complementary revascularization improves blood flow, while exercise improves muscle metabolism and conditioning. Combining them often leads to better functional outcomes than either modality alone.
What about the psychological aspects? Can interventions targeting motivation or behavior change help with exercise adherence?
There's some emerging evidence here. The guideline mentions that small trials have explored the use of psychological interventions. For example, techniques like motivational interviewing, which aim to build patient self-confidence and collaboratively resolve ambivalence about change, have shown some potential in small studies for improving daily step counts and possibly even reducing the need for repeat revascularization procedures later on. More research is likely needed, but it highlights the importance of addressing the behavioral aspects of exercise adherence.
Okay, so exercise is clearly a powerful, evidence-based prescription in itself, with different recommended approaches like SET and HBET, and strategies needed to improve uptake and long-term adherence. Now, let's pivot to talk about when procedures revascularization are considered.
Right, and the guidelines are very clear and consistent on the overall approach here. Revascularization is generally not the first-line treatment for intermittent claudication. The recommended approach is firmly stepwise.
Stepwise, what does that mean in practice?
It means starting with comprehensive risk factor management, addressing smoking, lipids, blood pressure, diabetes, implementing the best medical treatment, including antiplatelet therapy where appropriate, and crucially, initiating and supporting exercise therapy, ideally supervised or structured home-based, as the first step.
Okay, maximize conservative therapy first.
Exactly. Revascularization is then considered as a second step, but only for patients who are compliant with these conservative measures, but continue to experience disabling limb symptoms despite an adequate trial, usually at least 3 to 6 months, of medical and exercise therapy. This is a Class I, Level B recommendation.
So it's not just about having blockages visible on an angiogram. It's really about persistent lifestyle-limiting symptoms that haven't responded sufficiently to non-interventional management.
Precisely. The indication is driven by symptoms and functional impact, not just anatomy. And importantly, when considering revascularization, the principle of shared decision-making between the clinician and the patient is paramount.
What does that involve?
It involves a careful discussion considering the expected benefits of the procedure. How likely is it to improve their specific symptoms, their ability to perform daily activities, their overall health-related quality of life? This needs to be balanced against the potential risks associated with the procedure itself, both immediate and longer term. And it also involves discussing the long-term outcomes, including the durability of the intervention, the chance of the vessel reblocking, restenosis, or reocclusion, and the potential need for future procedures or complications.
So a very individualized discussion. Does the specific location of the arterial blockage influence the recommended revascularization strategy?
Oh, absolutely. The recommendations often differ significantly based on whether the primary disease driving the symptoms is located in the aortoiliac segment, the large arteries in the abdomen and pelvis, the femoral popliteal segment, the arteries in the thigh down to the knee, or the infrapopliteal or below the knee segment, the tibial arteries.
Okay, let's try and break down some of the key recommendations for these different locations, maybe starting high up with the aortoiliac segment. What's the general approach there for claudication?
For patients with disabling intermittent claudication who are undergoing revascularization for stenosis, that's narrowings in the iliac arteries, the guidelines suggest that balloon angioplasty with selective bare metal stent placement should be considered as the primary approach. Class II, Level B.
Selective stenting, meaning not always putting a stent in.
Correct. It means you perform balloon angioplasty first, and you only place a stent if the result of the ballooning alone is suboptimal. For example, if there's a significant residual narrowing, more than 30–50%, a flow-limiting dissection, a tear in the artery wall, or a problematic pressure gradient across the treated area. This is based on evidence suggesting that for iliac stenosis, this selective stenting strategy gives similar effectiveness and safety compared with placing a stent up front in every case.
Okay. What if it's a complete blockage, an occlusion in the iliac artery, not just a narrowing?
For complete iliac occlusions, the guidelines suggest that primary stenting, putting a stent in right away, may be considered. Class I, Level C. The rationale here is that stenting and occlusion might help reduce the risk of distal embolization, meaning debris or clot traveling downstream during the procedure, and might lead to better immediate and long-term patency compared to just ballooning and occlusion.
What about open surgery for iliac disease causing claudication? Is that still an option?
Yes, in certain circumstances. The guideline suggests that for patients with disabling intermittent claudication undergoing revascularization, who are considered to be at low surgical risk and have a reasonably long life expectancy, open surgery may be considered, class I, Bevel B, particularly for anatomically complex lesions. This might include extensive disease involving both iliac arteries or disease extending up into the aorta near the renal arteries, or renal involvement. Open surgery, like an aortoephemeral bypass graft, often provides excellent long-term durability or patency, potentially better than endovascular approaches for these very complex patterns, albeit with higher upfront risk.
Okay, so endovascular first is generally preferred for iliacs, especially for stenosis, with surgery reserved for complex cases in good risk patients. Now, let's move down the leg to the femoropopliteal segment, the superficial femoral artery, SFA, and popliteal artery. This is a very common site for lesions causing claudication, isn't it?
Extremely common, yes. And the guidelines have some quite strong recommendations here, including some important do not do points.
Okay, let's hear those first. What should generally not be done in the femoropopliteal segment for claudication?
Two key negative recommendations stand out. First, the routine use of atherectomy devices is not recommended. Class 3, Level A, meaning evidence of harm or lack of benefit. Atherectomy involves devices that physically remove plaque cutting, shaving, or sanding it away. While sometimes used selectively, the evidence from randomized trials has not shown a consistent benefit over standard balloon angioplasty for improving long-term patency in typical femoropopliteal lesions, and it adds cost and potential complications.
So, routine atherectomy is out. What's the second do not do?
The second one is about primary stenting. Placing a bare metal stent up front as the initial strategy is not recommended over performing plain old balloon angioplasty, POBA, first, with provisional stenting only if the POA result is suboptimal. Class 3, Level C recommendation against based on consensusless robust data. Again, trials have generally failed to show a significant long-term benefit for routine primary bare metal stenting compared to just ballooning the lesion effectively in this segment, especially given the mechanical stresses in the SFA that can lead to stent fracture or failure.
Okay, so avoid routine atherectomy and avoid routine primary bare metal stenting in the fempop territory. What should be considered then? What about drug-eluting technologies?
Yes, drug-eluting technologies played a significant role here based on better evidence. The guideline states that selective drug-eluting stent, DES placement, should be considered, Class 2 Hale Level B, if femoropopliteal plain balloon angioplasty leads to a suboptimal result. So if after ballooning you have a significant residual stenosis or a flow-limiting dissection, then placing a DES, which releases medication to inhibit scar tissue formation, is preferred over placing a bare metal stent in that situation. Trials have shown better patency rates for DES versus BMS when stenting is required in the SFA. Okay, DES if you need to stent. What about drug-coated balloons, DCBs? Drug-coated balloons are also important. The guideline recommends that adjunctive paclitaxel-coated balloon angioplasty should be considered, Class CI, Level A, strong evidence supporting this, for certain lesions in the femoropopliteal segment after achieving an optimal result with plain balloon angioplasty, meaning no flow-limiting dissection and minimal residual stenosis where you don't think a stent is needed.
So balloon the lesion first, get a good result, then inflate a drug-coated balloon in the same spot.
Essentially, yes. The DCB delivers the antiproliferative drug, paclitaxel in most current devices, directly to the vessel wall to help prevent restenosis without leaving a permanent implant like a stent. Numerous randomized trials have shown that this strategy significantly improves patency compared to using plain balloon angioplasty alone. The guideline also notes that earlier concerns about a potential long-term mortality signal associated with paclitaxel-coated devices have largely been refuted by updated meta-analyses of larger datasets and long-term follow-up for major trials. Cost-effectiveness analyses also generally support the use of DCBs in appropriate lesions.
Okay, that's helpful regarding the paclitaxel controversy. What about surgical options for femoropopliteal disease causing claudication, bypass surgery?
Yes, bypass surgery remains an important option, particularly for long or complex blockages in the femoropopliteal segment, where endovascular treatment might be less durable or feasible. If a patient is undergoing bypass surgery in this area, the guideline strongly recommends, Class 1, Level A, using an autologous vein graft. meaning using the patient's own saphenous vein harvested from the leg as the conduit for the bypass. Vein grafts generally provide the best long-term patency rates compared to prosthetic artificial grafts in this location, especially when bypassing below the knee.
Use the patient's own vein if possible. Any other specific surgical recommendations in this area?
Yes, one other strong recommendation, Class I, Level C, is that open surgery, specifically an endarterectomy, cleaning out the plaque, often with patch angioplasty, widening with a patch, is recommended for significant disease affecting the common femoral artery bifurcation, that critical junction in the groin where the main femoral artery splits. This area is crucial for inflow to the rest of the leg, and surgical repair here is typically very durable and often preferred over endovascular treatment for complex bifurcation lesions.
Okay, common femoral surgery often preferred. Now, let's go further down below the knee to the tibial arteries. Treating isolated disease here just for claudication symptoms seems controversial.
It is, and the guideline provides a very strong do not do recommendation here for patients whose only symptom is intermittent claudication. It states that revascularization procedures aimed at opening isolated below-the-knee lesions, whether done using endovascular techniques or open surgery, are generally not recommended. Class 3, Level C harm potentially outweighs benefit,
Why is that?
primarily due to the risk of harm versus limited expected benefit for claudication symptoms. The tibial arteries are small, procedures carry risks like dissection, thrombosis, or embolization, and the long-term patency of interventions here is often poor. Restenosis rates are high. Furthermore, occluding a tibial artery during an attempted procedure could potentially worsen the situation or even precipitate critical limb ischemia. The guideline specifically mentions that tibial bypass surgery performed solely for intermittent claudication has been associated with poor outcomes in historical series. The risk-benefit balance is generally considered unfavorable when the limb is not imminently threatened.
So, for claudication alone, leave isolated below-the-knee disease alone. Are there any exceptions mentioned to that recommendation?
Yes, the guideline acknowledges very specific, extreme, highly selected scenarios. In these rare cases where a procedure targeting below-the-knee lesions is deemed absolutely necessary in a patient with truly disabling intermittent claudication that hasn't responded to anything else, then balloon angioplasty, potentially with selective use of a drug-eluting stent, DES, may be considered Class I Level C. Similarly, in very extreme circumstances where exhaustive non-invasive treatment and endovascular therapy aren't effective or possible for disabling claudication thought to originate from tibial disease, using a vein bypass may be considered Class I Level C, but again, this would be highly exceptional.
Okay, so the threshold for intervening below the knee purely for claudication is extremely high, strongly discouraged in almost all cases.
Precisely. The primary approach for claudication driven by tibial disease is maximal medical therapy and exercise. You generally only intervene below the knee if the patient has progressed to chronic limb-threatening ischemia, CLTI.
Right. Okay, so assuming a revascularization procedure has been done, whether iliac, femoropopliteal, or in those rare tibial cases, what's the focus of care immediately afterwards and long-term? Preventing future events and maintaining the restored blood flow must be key.
Exactly. Post-procedure care heavily involves optimizing medications to prevent clots forming either at the intervention site or elsewhere in the cardiovascular system. This involves using antithrombotic therapy to reduce the risk of the vessel reblocking, thrombosis or restenosis, and also to lower the systemic risk of MACE and MALE.
The guidelines discuss different antithrombotic strategies here, right? Single antiplatelet therapy, SAPT, dual antiplatelet therapy, DAPT, and maybe combinations involving anticoagulants.
Yes, there's been a lot of research in this area, trying to find the optimal balance between preventing ischemic events and causing bleeding. The guidelines discuss the roles of SAPT, usually aspirin or clopidogrel alone,
Yep.
DAPT, typically aspirin plus clopidogrel, and newer combination therapies, most notably the strategy tested in the Voyager PAD trial using low-dose rivaroxaban, a direct oral anticoagulant, plus aspirin.
Okay, let's talk about that Voyager PAD trial strategy, as it seems quite significant based on the recommendations. What did it show?
The Voyager PAD trial was a large, important study. It specifically enrolled patients with PAIN who had recently undergone lower extremity revascularization, either endovascular or surgical. It demonstrated that adding low-dose rivaroxaban, 2.5 milligrams twice daily, to background aspirin therapy significantly reduced the composite risk of major adverse cardiovascular events, AMAC, and major adverse limb events, MALE, compared to aspirin alone. Based largely on this trial, the guideline gives a Class 1 Level A recommendation for considering this combination therapy in these post-revascularization PAD patients.
A significant reduction in May and male events. That sounds very positive. But you mentioned balancing ischemia and bleeding. What's the trade-off with the rivaroxaban plus aspirin combination?
Yes, there's always a trade-off with more potent antithrombotic regimens. While the combination significantly reduced ischemic events in Voyager PAD, it also led to a significant increase in major bleeding events, specifically TMI major bleeding, though not significantly more fatal or intracranial bleeding compared to aspirin alone. The guidelines highlight this increased bleeding risk with an equally strong Class I Level B recommendation.
Okay, so it works well to prevent clots and limb issues, but causes more bleeding. How do you decide who should get this more intensive therapy?
That's the crucial clinical question. The decision to initiate more intense antithrombotic therapy like rivaroxaban plus aspirin needs to be highly individualized for each patient. It requires careful shared decision-making, weighing the patient's estimated risk of future ischemic events, both cardiovascular and limb-related, against their individual risk of experiencing harmful bleeding complications. Assessing and, where possible, correcting any modifiable bleeding risk factors before starting therapy is also really important.
Does the guideline mention any tools to help assess bleeding risk?
Yes, it notes that several bleeding risk scores exist, developed from various patient populations, like atrial fibrillation or coronary disease, which might help clinicians estimate a patient's baseline risk of major bleeding. These scores typically incorporate factors like advanced age, for example over 75 or 80, presence of chronic kidney disease, history of stroke, previous bleeding episodes, concurrent use of other medications like NSAIDs, labile INR if on warfarin, anemia, or thrombocytopenia. While not perfectly validated specifically for the post-PAD revascularization setting, they can help frame the risk discussion.
Okay, so assess both ischemic and bleeding risk individually. What about dual antiplatelet therapy DAPT, like aspirin plus clopidogrel, specifically after endovascular procedures for claudication? Is that routinely recommended?
The recommendation here is a bit more nuanced and less strong than for the rivaroxaban combo post-revascularization generally. The guideline states that for patients with intermittent claudication who have undergone endovascular revascularization of the lower limb, for example, angioplasty, stenting, and who are not considered to be at high risk of bleeding, initiating DIPT, usually aspirin plus clopidogrel, for a duration of between a minimum of 1 month up to a maximum of 6 months may be considered. Class I, level C.
Okay, be considered. So not a strong recommendation.
Right. It's a weaker Class I recommendation based more on consensus and extrapolation from other vascular beds like coronary stenting, as historically there's been less robust PA-specific randomized trial evidence directly comparing DIPT versus SAPT purely for endovascular claudication treatment in terms of long-term mesenchymal outcomes versus bleeding. The optimal duration within that 1 to 6 month window is also unclear and likely depends on the complexity of the procedure and patient risk factors.
Okay. What about the scenario of triple antithrombotic therapy? Say, needing aspirin, clopidogrel, and an anticoagulant like warfarin or rivaroxaban concurrently?
The guidelines are generally quite cautious about triple therapy due to the very high bleeding risk. They specifically address one scenario. In the rare post-revascularization situation where triple therapy is deemed clinically necessary, perhaps due to coexisting atrial fibrillation requiring anticoagulation, plus a recent stent requiring DAT, particularly after surgical revascularization, patients who are receiving aspirin and low-dose rivaroxaban, as per the Voyager PAD regimen, should not have clopidogrel continued for longer than 30 days. This is a Class 3 Level C recommendation advising against prolonged triple therapy in this context, suggesting that the bleeding risk likely outweighs any potential incremental ischemic benefit beyond the first month.
Okay, be very wary of prolonged triple therapy. Looking further ahead now, beyond the immediate post-procedure period, what's involved in the optimal long-term care and follow-up for patients with PAD, especially those who've had interventions?
Long-term follow-up is absolutely crucial. We know that sustained adherence to all the guideline-recommended therapies we've discussed, ongoing smoking cessation, regular physical activity, taking prescribed medications like statins, antiplatelets, antihypertensives, diabetes medications, is strongly associated with reduced future MACE and male events. So follow-up is partly about monitoring and reinforcing adherence to these foundational treatments.
Is routine surveillance with imaging, like ultrasound, recommended after revascularization procedures to check if they're staying open?
Yes, but primarily for one specific type of intervention. Bypass is constructed using the patient's own vein, typically infrainguinal vein grafts, like a femoral-popliteal or femorotibial vein bypass. For these vein grafts, the guideline recommends duplex ultrasound surveillance, Class 1, Level B.
Why specifically for vein grafts?
Because vein grafts, particularly in the first year or two after surgery, are prone to developing narrowings, stenoses, within the graft itself or at the connection points, anastomosis. These stenoses are often clinically silent initially, but can progress rapidly to cause graft thrombosis, blockage, if left untreated. Duplex ultrasound can effectively detect these failing grafts by identifying areas of high-velocity flow. Identifying and treating these stenoses proactively, for example, with angioplasty, can often salvage the graft, prevent occlusion, maintain limb perfusion, and avoid the need for repeat surgery or potential amputation. The guideline notes the cost associated with this surveillance is generally considered justified by the avoided costs and morbidity associated with graft failure and limb loss.
Okay, so routine ultrasound surveillance for vein grafts makes sense. What about after endovascular procedures like angioplasty or stenting? Is routine surveillance recommended then?
The utility of routine duplex ultrasound surveillance after endovascular interventions, like SFA stenting, is considered less clear based on the available evidence mentioned in the guideline. While restenosis certainly occurs after endovascular procedures, it may not always be hemodynamically significant or require intervention, and studies haven't consistently shown that routine surveillance and preemptive treatment of asymptomatic restenosis after endovascular procedures improves long-term outcomes or patency compared to just monitoring patients clinically and intervening if symptoms recur. Therefore, routine surveillance is not as strongly recommended as it is for vein grafts. Clinical follow-up remains key.
Got it. You mentioned earlier the concept of patient-reported outcome measures, or PROMs. Where do they fit into the long-term follow-up picture?
PROMs are increasingly recognized as really valuable tools in PAD management and follow-up. They are essentially structured questionnaires that capture the patient's own perspective on their health status, symptoms, function, and quality of life. The guideline suggests that using validated PROMs should be considered Class IA Level C during follow-up.
Why are they important?
Because they provide a practical way of integrating the patient's voice directly into the assessment of their condition and the effectiveness of treatment. They often capture aspects of the disease burden, like limitations in daily activities or social function, that might be missed by purely objective measures like ABI or treadmill distance. Studies have shown that PAD-specific PROMs, like the Vascular Walking Impairment Questionnaire, WIOQ, or Peripheral Artery Questionnaire, PAPQ, are more sensitive for detecting changes relevant to PAD patients compared to generic quality-of-life tools. Using PROMs helps you understand how the patient feels and functions in their real life, which complements the objective data and helps evaluate treatment success from the perspective that matters most to the patients.
So it's about capturing the subjective experience alongside the objective data, asking how are you doing in a structured way.
Exactly. It helps ensure that treatment goals align with the patient's priorities and measure success based on what impacts their daily life.
What role might technology play in supporting long-term follow-up and management? Things like telemedicine or apps.
The guideline acknowledges the potential of remote and digital health solutions. Things like telemedicine consultations, mobile health applications, health apps, for tracking activity or symptoms, and wearable sensors can potentially support follow-up, enhance patient self-management, and improve adherence to treatment plans. It references the VVA trial, for example, which showed that structured telephone counseling significantly improved adherence to statin therapy in PA patients. These digital tools offer opportunities to strengthen care delivery, perhaps making follow-up more convenient or frequent, potentially even reaching patients in their homes more effectively.
And finally, regarding long-term care, the guidelines recommend the continuous assessment of quality indicators. What does that entail?
Yes, it's recommended, Class I Level C, that healthcare systems or providers organize and maintain ongoing assessment of suitable quality indicators related to PAD treatment. This means systematically tracking key outcomes, like patient survival rates, changes in functional status, perhaps using PROMs, rates of procedure-related complications, and the incidence of MACE in male events over time. The idea is that by continuously monitoring these quality metrics, providers and systems can identify areas for improvement and refine their processes to ensure they are delivering the highest standard of evidence-based care to PAD patients consistently. It's about quality assurance and continuous quality improvement.
Okay, that gives us a comprehensive picture of the guidelines recommendations across the board: diagnosis, lifestyle, medical therapy, exercise, revascularization decisions, post-procedure care, and long-term follow-up, including PROMs and quality monitoring. Now, let's maybe zoom out a bit again and look at the broader context. How does PAD affect different populations? Are there important considerations related to sex, socioeconomic factors, or ethnicity that clinicians should be aware of?
Yes, this is a really crucial area that the guideline touches upon, highlighting important disparities and factors that influence the disease beyond just the clinical parameters.
Let's start with sex differences. Does PAD affect men and women differently?
Well, overall prevalence seems to be roughly similar between men and women, although some studies suggest maybe slightly higher rates in men at younger ages and women catching up or surpassing at older ages. However, a major point the guideline makes is that women have historically been significantly underrepresented in most major PA clinical trials, particularly intervention trials.
So our evidence base is potentially biased.
It means it's harder to definitively identify potential sex-specific differences in risk factor impact, disease presentation, treatment response, or outcomes, because the data is often predominantly from male participants. For example, studies show only a minority, sometimes less than 30%, of patients enrolled in PA trials have been women. There's a clear need identified to improve the enrollment of women in future clinical trials to better understand these potential differences.
Are there any suggested differences in risk factors or management approaches between the sexes that are mentioned?
The major risk factors like diabetes, high cholesterol, and tobacco use seem to increase PA risk substantially in both sexes, perhaps around fourfold, according to some data cited. While smoking rates have generally declined, the decline has perhaps been slower among women in some regions. The guideline does note potential differences in management and achieving treatment targets. Some studies suggest men might be more likely than women to be treated with intense cholesterol-lowering therapies, and female sex itself might influence the diagnostic and therapeutic approach for diabetes, potentially leading to delayed diagnosis or women being less likely to achieve target HbA1c levels compared to men in some settings. Despite these potential disparities, the overarching recommendation, Class I, Level B, is that similar evidence-based cardiovascular preventive strategies should be offered and implemented for both men and women with PAD. The goals are the same.
Okay, what about socioeconomic factors? Does poverty or social status play a role?
Yes, significantly. The guideline states that lower socioeconomic status is clearly associated with a higher incidence of PA. Furthermore, patients from lower socioeconomic backgrounds tend to experience worse clinical outcomes after diagnosis and may have lower rates of utilization of recommended preventative medications like statins or antiplatelets. This really highlights the impact of social determinants of health and disparities in healthcare access, quality, and adherence.
And are there geographic variations mentioned?
Yes, the guideline notes wide variations in health spending, treatment patterns, example rates of revascularization versus amputation, and outcomes across different countries and even within regions of the same country. This suggests that factors beyond just patient biology like healthcare system structure, funding, local expertise, and practice patterns significantly influence the care that PA patients receive.
What about ethnicity? Are there known differences?
The guideline touches on this, noting, for example, that individuals of African ethnicity may have higher rates of insulin resistance, which could potentially contribute to presenting with more severe stages of PA. More concerningly, it highlights that patients of African American ethnicity, in particular based on U.S. data, seem to carry a higher risk of worse outcomes after PA treatment. This includes higher rates of major amputation and mortality compared to white patients. They're also reportedly more likely to undergo primary amputation as the first treatment for acute PAD presentations, rather than attempts at revascularization. This points towards significant worrying ethnic disparities in both disease severity at presentation and subsequent management pathways and outcomes.
That's deeply concerning and highlights areas needing urgent attention. Finally, let's just circle back one more time to diabetes, which we've threaded throughout the discussion as such a major player.
Yes, it's worth re-emphasizing its profound impact. As we covered, diabetes dramatically increases the risk of developing PAD, often leads to earlier onset and more severe multi-level disease, and is associated with poorer lower extremity function. Critically, it significantly increases both long-term mortality and the risk of limb loss in patients with PA. Even after interventions, outcomes are generally worse if diabetes is present. Therefore, the guideline strongly reiterates that achieving tight glycemic control, aiming for HbA1c 7%, and aggressively managing all other cardiovascular risk factors lipids, blood pressure, smoking, remain absolutely critical in patients with both PAD and diabetes in order to reduce their very high risk of both me and male events.
So it's clear that while PAD is fundamentally a condition of blocked arteries, truly comprehensive care requires understanding and addressing the patient's broader context, including their sex, socioeconomic background, ethnicity, and critical comorbidities like diabetes, as these factors profoundly influence risk, presentation, access to care, and ultimately outcomes.
Absolutely. You cannot manage the disease effectively without considering the whole patient and the systemic factors at play.
This ESVS guideline is incredibly comprehensive, pulling together a vast amount of evidence and providing clear recommendations on so many aspects of PAD care. But as with any complex field, even with such a detailed document, there are always going to be areas where the evidence is less clear or where more research is needed. Did the guideline writing committee identify specific unresolved issues or future research needs?
Yes, they did. They explicitly listed several important areas where further research is warranted to refine our understanding and management. One significant unresolved issue they highlight is the lack of a single, common, validated anatomical classification system that effectively covers all stages of peripheral arterial disease.
We have systems like Rutherford for clinical stage and TASC for aoroiliac femoropopliteal lesions, right?
Exactly. But the widely used TACIT-2 classification, while useful historically for defining lesion complexity in trials, is considered somewhat outdated now for guiding specific intervention choices, especially with modern endovascular techniques. And newer systems that have been proposed, like GLAS for CLTI, are specific to the more severe stages. There isn't one universally accepted, detailed anatomical grading system that works well across the spectrum, from asymptomatic PAD through claudication to CLTI. Having such a system would be really helpful for standardizing research reporting and facilitating clear clinical communication about lesion complexity and treatment planning.
That makes sense, a common language for describing the anatomy across all stages. What other research questions were highlighted?
Several others. For example, needing more data on the potential benefits and harms of SGLT2 inhibitors, specifically within different PAGI subgroups, like claudicants versus asymptomatic versus CLTI, the long-term risks and benefits of using e-cigarettes as a tool for smoking cessation in PAD patients remain largely unknown and require study. In terms of antithrombotic therapy after revascularization, more evidence is needed to directly compare different strategies like DABT versus SAPT versus combination therapies like rivaroxaban aspirin, especially after endovascular procedures, to clarify the optimal regimen and duration. Similarly, the role of newer antithrombotic agents and even the benefits of statins themselves, specifically within the large asymptomatic PAD population, needs further investigation through dedicated randomized controlled trials. Defining the most appropriate LDL cholesterol targets for different PAD subgroups is also mentioned as an area for refinement. Other questions include understanding the benefits and harms of polypharmacy in the very elderly PAD population, for example, those over 85. How can mobile health technologies and wearables be most effectively deployed to support sustained lifestyle changes in PD patients? Which patients are most suitable for invasive treatments as outpatients versus inpatients? We need more high-level evidence directly comparing open surgical versus endovascular revascularization strategies, particularly for patients with intermittent claudication, looking at long-term functional outcomes and cost-effectiveness. The long-term outcomes of interventions, specifically in the common femoral artery, also need more robust data. And finally, further clarifying the precise role, benefits, and harms of specific adjunctive endovascular techniques like atherectomy or intravascular lithotripsy within the intermittent claudication population is still needed.
Wow, that's quite a significant research agenda. It really underscores that even with such comprehensive and well-researched guidelines, the field is continuously evolving and we're always learning.
It certainly is. These guidelines represent the current state of the art based on available evidence and expert consensus, but openly identifying these unresolved issues and knowledge gaps is absolutely crucial for guiding the next generation of research that will ultimately lead to even better patient care in the future.
Well, we have certainly covered a tremendous amount of ground in this deep dive today, pulling out the key insights and recommendations from these important European Society for Vascular Surgery guidelines on asymptomatic PAD and intermittent claudication.
We have. And I think the key takeaways are clear. Lower limb peripheral arterial disease is a highly prevalent condition, maybe more common than many realize, and importantly, it often exists silently, without classic symptoms. But whether silent or symptomatic, it acts as a critical warning signal for underlying systemic atherosclerosis and a significantly increased risk of future heart attack, stroke, and limb complications.
And while the prospect of having atherosclerosis anywhere in the body can certainly sound daunting for patients, I think the overwhelming message from these guidelines is actually one of hope and empowerment. With the right knowledge and the right strategies, you, as clinicians and your patients, can significantly impact the disease course.
Absolutely. Through those foundational lifestyle changes, especially smoking cessation and regular exercise, combined with effective, evidence-based medical management targeting risk factors like blood pressure, lipids, really aiming for that aggressive LDL target we discussed,
Yeah.
and diabetes, using those beneficial SGLT2 inhibitors or GLP-1 agonists when appropriate, and potentially using antiplatelet or antithrombotic therapy judiciously. The progression of the disease can be slowed, and those serious cardiovascular and limb risks can be substantially reduced.
And for those patients who do develop disabling symptoms like intermittent claudication, exercise therapy stands out as a powerful, class I recommended first-line treatment. And only when symptoms persist despite maximal non-interventional efforts should revascularization procedures like angioplasty, stenting, or bypass surgery be considered, always tailored carefully to the individual patient and the specific location of the blockage, while also being mindful of those techniques or situations where intervention is generally not recommended, like routine atherectomy or isolated tibial intervention for claudication.
And let's not forget the importance of that long-term follow-up, reinforcing adherence, monitoring for complications, using surveillance wisely, especially for vein grafts, and crucially, incorporating the patient's own voice and perspective through the use of patient-reported outcome measures, PROMs. Tracking progress needs to encompass both objective findings and how the treatment is actually impacting the patient's life.
Ultimately, managing PID effectively, whether it's asymptomatic or presenting with claudication, is clearly a multifaceted, long-term process. It requires skillfully integrating all these evidence-based treatment components with a deep understanding of the individual patient's clinical context, their risk profile, their values, and their goals. These guidelines provide a really strong, robust framework to help us do just that.
It really empowers clinicians and patients alike to engage in that vital process of shared decision-making, grounding those decisions in the best available evidence while always considering the unique circumstances of the person sitting in front of you.
So as we wrap up this deep dive, perhaps here's a final provocative thought for you, our listeners, to consider. Given the remarkably high prevalence of asymptomatic peripheral arterial disease that we've discussed, and its potent association with future cardiovascular mortality and morbidity, maybe the simple, non-invasive, relatively low-cost ankle brachial index test should be even more widely and systematically utilized in clinical practice, particularly in individuals with key risk factors like smoking or diabetes, even if they have no leg symptoms. Could it serve as a more routinely sought early warning signal, prompting earlier and more aggressive implementation of those proven preventative measures? It's something to think about. Despite having these robust guidelines, the ongoing journey of discovery and refining our approaches means that staying informed isn't just helpful for optimizing care for patients with PAD, it's absolutely essential.